Welcome back, everyone. I'm going to turn it over to Dr. Andrew Kwanback.
Hi, everyone. Well, we're entering the home stretch here. Thanks for attending and being a part of another wonderful short course. I know that I've learned a lot, as I do every year that we host this event. I do want to take a quick minute to personally acknowledge all of the hard work and dedication of our many friends and colleagues who are out battling COVID-19 on the front lines right now. Times are definitely tough here in Wisconsin and in many parts of the nation. So thank you for your personal sacrifice and your commitment to public health. We are going to wrap up our main session here by covering some emerging questions that have come through over the course of these last few days. I'll mention a couple of them here, and then we're going to have a little interactive event or a Menti poll, I think, and I'm going to turn it over to Felice to explain how that's going to work. But we're looking at a couple of different topics. Addressing health equity has come up a number of times. Navigating organizational structures. How do we understand who the decision makers are in organizations and situate implementation in ways that promote success? Choosing where to begin with context. CFR has 37 constructs, and it's not always evident where the best place to intervene in a certain organization for a certain project would be. So that's something that's come up a number of times. Likewise, choosing where to begin with strategies. Eric lays out, I think it's 73 different strategies, and we don't have a great sense as to what we should be, exactly which strategies to choose to have success in different types of projects. And then finally, obviously COVID-19 is really dominating all of our lives at this time. So there's a lot of implementation challenges around COVID-19 that are relevant to all of our lives and implementation research in particular. So with that, Felice, can I ask you to put up the rankings?
Yes. So they are up, and I see some of you have already started to rank. If you don't have Menti up on your phone or on your internet browser, now would be a good moment to pull it up and rank some of these topics that you are interested in. These are kind of distilled down from conversations we have all had over the past few days. And we are really excited to be able to spend the rest of this session addressing that. I'll keep it up for a couple of minutes, but I will let the rest of the panelists and facilitators and guest faculty get ready to start answering all your questions. And if more things come up that are not addressed here, feel free to put them on Menti, and if time allows, we will start asking additional questions from there. Thank you.
Mm-hmm. So Byron and Laura and Jane, Felice, everybody, we'll give it a minute here for people to weigh in Menti, but certainly looks like an early lead is coming out around addressing health equity, and we all I think acknowledge how fundamentally important that is. One of the things that came up in discussion in the afternoon session yesterday, I think, was that there's kind of a fundamental tension between, we talk a lot about organizational readiness as something to assess, and we're looking for organizations to be ready for change. And a lot of times, if we're going to be working with sites that are ready to change, that might have the effect of exacerbating health disparities. So that's something that, it's an open question. This is the emerging question portion of the session, and I don't know that we have a lot of great answers, but just something to be aware of. And then I guess coming through here, this theme of prioritizing, I think, is coming through with number 2 and 3. Which makes a lot of sense. It's something that I've struggled with in my work. What strategies to pick out of the ERIC taxonomy. This is something I'd actually like to hear from all the panelists, particularly Byron. What kind of evidence do we have for the effectiveness of different implementation strategies? I think, the evidence base is emerging, so it's fairly thin in a lot of cases. So we pick the strategies that we think will work, but we don't have a lot of faith going in a whole lot of strategies based on the evidence. Likewise, choosing where to begin with context. Again, 37 constructs in CFR, and I think we have a similar kind of challenge where it's not totally clear which of the, what's most important to target in an implementation project, which elements of the context should be focused on first. So I'll just leave it there. Those are the top 3. Looks like that's kind of stabilizing. And any initial thoughts?
It's time we get started. I'll leave this on in the background so you can continue if you haven't had the opportunity to vote, but we can proceed. Thanks.
Okay, thank you, Felice. Byron, Laura, any initial thoughts?
Yeah, I'm looking at the mentee. It was really fun watching it. It was like context strategies. It looks like, health equity strategies is neck and neck with health equity now. I would, posit that, really strategies and context are kind of intertwined anyway. So depending on where we start with that, but that could be our second topic. But really, I think we all really appreciate the interest and the priority in addressing issues around equity. I have to say that I just do not have experience in this field. I know that there are researchers who have spent decades on topics related to anti-racism and other disparities, other issues, other, whether it's, all kinds of, many different dimensions. But I think that with especially the death of George Floyd this summer and all of the protests, really turning a focused lens on anti-Black racism specifically. And one of the things that I'll just kind of highlight, why not focus on all forms of racism? Actually, we need to, definitely we need to. I put a link into chat to a community of practice survey that you can click on and sign up. There are a series of questions. Anna Bauman and others at Washington University in St. Louis and others, colleague of Byron's, has really kind of taken the charge, and this has grown, I think, way bigger than any of them dreamed when they were all sitting in a room and recognizing this topic as really important. I've been privileged to be able to be a part of those conversations, kind of following from that first kind of trigger point when the community of practice was formed or the idea was formed. But one of the things that I will say is the justification for this group, within this community of practice to focus on anti-Black racism, is that, we as implementation scientists can appreciate that context and history is different and unique to different groups of people, to organizations certainly. And the history and the experience and therefore the solutions and the way to look at it would be different for Black Americans and dealing with racism within that population in this country versus Native Americans, which have their own issues and their own history. And Hispanics and Asians, anyone with Black or brown skin, definitely all really huge issues at many levels, every level, I guess I could say, within this country. So anyway, this community of practice is focusing on anti-Black racism. And, the driving question is, how do we integrate anti-racist approaches and considerations and lenses to our work? And so I'm not going to pretend by any means to be an expert. I am, as you can see, a white female. I do not have the lived experience of being Black in America. So maybe there are others who could add to the chat or add to Mentee. We're looking at the work, like critical race theory, equity frameworks. Chandra Ford is a name that I'm becoming familiar with. Amy Kilburn also has developed several years ago an equity framework. Yeah, and Jane, I think that, in thinking, I think that's the kind of the enormity of the problem, is that there are opportunities for structural racism and also, individual acts of racism, racist behaviors to manifest themselves in all kinds of ways in just about every construct within the CFR. So it does seem like, you could definitely approach a framework like the CFR with the lens of equity that would add dimensions to many, if not all, of the constructs. And I would posit, and Byron, maybe you can pick up here on the strategy side of the coin. How do we design strategies so that we're not exacerbating disparities at a minimum? At a next level, how can we improve equity? And as a stretch goal, but really urgent goal, how can we dismantle structural racist structural systems by the way we design our strategies and approaches, and the way that we're even looking at, the lens through which we approach our implementation challenges.
And I would just add, I saw this question and Mentee liked a lot of times earlier. I don't have it up right now, but for those looking to plug into work in this area, I think that would be a fabulous group to join. And they've sort of framed some priorities that they have in relationship to these issues. But I think, needless to say, it's an ambitious goal to address these things, and it's really critical work that I think is going to, it's forcing us to examine all of our institutions and our research in ways that I think we haven't done. This is not to throw implementation science under the bus, but I just doing a word search for racism in the journal Implementation Science, this was, maybe a month or two ago, but I think there were like 3 mentions or something like that in the history of the journal. And not to point the finger at them, I then started going through my own manuscripts and opportunities that I would have had to address issues like systemic racism and often I referred to stigma and other things that are sort of social level factors and have not addressed racism head on. So I think, as a field, we really need to do a lot to bridge these areas.
Yeah.
Just want to say quickly, I really like this paper by Anna Bauman and Leo Cabasa on reframing elements of implementation science to address inequities. And some of it is really focusing on reach from the very beginning, designing and selecting an intervention for vulnerable populations with interventions and with implementation in mind. And I think on that front, oftentimes some of the interventions that we're implementing that are well-established evidence-based practices, when we actually look at the populations that are included in the trials, we find that they're often much less diverse than we would want them to be. So I think we have a lot of problems even just when we think about our interventions. I'm actually struggling a little bit with conceptually how we think about implementation strategies in this space. And Lauren, I think, talked about work led by Deborah Bingham and colleagues at Maryland to sort of think more about that conceptually. But in some ways, that's harder for me to think about. So I'd love to hear people's thoughts on that.
Yeah, I'll just make a shout out to Heather King in chat, who made a comment that, certainly as implementation researchers, one approach that we can use just right away is to ensure that the participating settings are representative or possibly over-representative of settings that serve minority populations, or populations of whether it's Black Americans, Native American, populations that have exhibited measures of disparities within the topic that we're implementing. And I think that one of the things, Byron, when we think about okay, I'm gonna I've done some work, and my colleagues have done some work in, for example, de-implementing or de-intensifying intervention. So backing off on medications, saying, no, you don't need that carotid artery screened, et cetera. Maybe even, other types of screening that are not necessarily efficacious or, effective, given the situation of the patient. But when people of color who have been historically kind of not listened to and undertreated may have great difficulty receiving that message. And so when we think about implementation strategies, I can imagine them being different or having a different priority, certainly have a difference in the way that they're operationalized when addressing a topic like this among populations with exhibited disparities. And that so that's like one kind of immediate way that I can think of that, the strategies would be tailored or adapted differently. Heather, you also mentioned Leslie Hausman in Pittsburgh, I believe. She's with the VA. She has actually a center that is focused specifically on issues of equity, and she's creating a dashboard, an equity dashboard for clinicians, for clinics to use. And really, she's been piloting that. And, to me, that's a really fascinating question, because like we're building dashboards that give feedback on clinical measures, like appropriate use of proton pump inhibitor medications, for example, among patients with high risk for bleeding. And how do we incorporate, a dashboard that focuses specifically on equity, or can we, build in a lens or a breakout for looking at the topics of equity specific to that particular topic, so that clinicians can have quick, easy access to, where are the disparities within my panel of patients. And yeah, so I guess, just kind of throwing that out. I mean, that also begs for the possibility of tailoring or choosing different strategies for outreach, maybe doing outreach among populations with exhibited disparities to try to address inequities. And the strategies may be different for those populations versus non, or let's say, white populations that have different treatment patterns. Maybe it's, a multi-level outreach is not necessary among them, because maybe they come to the clinic more often because they have more trust in the health system.
One of the things that I think it really begins with some intentionality and understanding that, if structural racism implies somewhat that if we don't intentionally pay attention to understanding how the structures reinforce it, that we are contributing, even in implementation science, to worsening disparities. And then I think along with that intentionality comes that whether you're using CFR or implementation strategies to specifically include stakeholders, both as workers and implementers and as patients or the target group, include those stakeholders who can tell you how this will affect them, how the system and the structures of whatever system it is, intersetting, out-setting, affect them. And then by intentionally hearing that, you can, I think, begin to build that in to the strategies. So there's probably additional barriers related to race, color of skin, ethnicity that, that create challenges to implementation.
Yeah, and that reminds me of the presentation we heard this morning from Barb and Lindsay, where they bake that in right in the beginning. So, you know, it may be a matter, I mean, within participatory and co-design scenarios, being very intentional about including people of color, for example. And I also struggle with, you know, there are issues inside the organization as well. So, you know, when we talk about including, you know, people of color, it's not just patients and, you know, what the treatments are and how they're reaching, but it's also participation and giving voice to employees within the system.
Byron, you mentioned a paper by Leo Cabasa, and he was our guest faculty 2 years ago, and we focused on implementation research and health disparities. I wonder if you could put that into the chat. And it's, I mean, I think from my perspective, it goes to show we have a short course 2 years ago, and things have not gotten better by themselves, which does speak to the fact that I think we all have to be very intentional about this at every step. So just talking about it isn't enough. We have to build it into our projects, as you mentioned. So there's a lot of questions, comments coming in the chat, and I think people are still using Menti as well. I'm not sure if I can. I'm not sure if I can keep up with all of them, but here's one. I'm just going to kind of start from the bottom. Given how popular education of health professionals is as an intervention component, it seems to me that we can intentionally design education materials to have at the forefront the issue of structural racism and its effect on different populations. At least in chronic disease, guidelines for clinical treatment do already acknowledge differences based on race. Let's see.
I think it will be interesting to challenge ourselves to include in our research publications that intentionality around health equity lens and how that was applied. You know, that may need to be just as we think about what it takes to do rigorous science, it may be a component that we need to apply and report on. And it would be interesting to see how that does change the field.
It's interesting, Jane. I've been talking with some folks about, just like we have sort of reporting guidelines for other things, you know, could there be reporting guidelines for this? And I guess I've sort of thought about it, not to diminish the importance, but in the sense of like, just like CBPR or sort of like, you know, your approach to partnered research, it can vary, and people's probably the extent to which people's projects are going to focus directly on health disparities might vary greatly. But to be sort of forced to have to reflect upon that and, you know, how it does or does not impact your work, I think would be a cool thing.
You know, one thing that occurred to me as implementation researchers, we really want to build up tension for change, you know, and you know, that is defined as people feeling like they're in an intolerable position and they have to do this change to address that tension. And so what can we as implementation researchers do to build and maintain actually a strength of tension for change around racism? So, you know, we want this to be not a moment, but a movement. And I think keeping these issues visible, and, you know, I love the idea of reporting guidelines. You know, what would those look like? Of course, there are a lot of different dimensions and a lot of subgroups to, you know, really pay attention to. But I think that that is a big challenge. And, you know, we have a degree of a soapbox in a way, or a podium, I guess, that, you know, we as a community can certainly, you know, unify our voices as to the urgency and the importance of doing this. But we also need to have that level of urgency within the health systems, you know, that we work with as well.
Yeah, just a thought on some of the reporting guidelines. And when we had our short course a couple of years ago, the other guest faculty was Russ Glasgow, who developed the REAIM framework, and I'm using that in some of my work. And so I think it's really important to be very, very intentional about the reach element of REAIM, and be tracking that kind of from the beginning to make sure that the populations that we're reaching in our projects are diverse. And you know, that's something that often doesn't happen without intention. So
Yeah, that's actually, yeah. Sorry about that, Andrew. That was a great point about REAIM, because that reminds me that baked into the dimension related to reach is representativeness. And that would be a key measure and part of really the impact, you know, when you take reach times effectiveness, that is our public health impact.
Yeah, I guess. No, just one last point, I guess, on that issue. I'm reflecting on just work that I'm doing every day, basically. You know, we're recruiting for a mobile health study, and I think it's just important, as we're seeking to recruit 546 patients, give or take. And we're about 100 patients in, and I think we have to be constantly reflecting on what kind of a population that we're reaching in our recruitment efforts, and then changing tactics, you know, based on what we're seeing come in. So it's something to be really intentional about at every step, and it implies a need for kind of real-time monitoring of enrollment and recruitment and studies that we're doing.
I definitely agree. And I know that there are so many excellent resources and thoughts everyone has, and I encourage you to keep putting those on chat. But we also have so much engagement going on with the Menti Q&A and the other topics that I want to make sure we address some of those as well. So this would be a nice time to kind of gently shift to the next topic.
Oh, great. Okay, so the next topic, do you want to go back to the top 5? Okay, so choosing where to begin with strategies. So this is, I guess, I'll look to Byron for this one. I mean, a question I have, and I don't want to dominate the discussion by any means, but what do we know about which strategies are most effective based on what we're learning, you know, through all of the research that's going on now that we have more sort of codified research with these different strategies? What seems to be working? Do we know at this point?
Yeah, that's a great question, Andrew. And I know, and maybe you can speak to this in your own research. I know you've drawn on systematic reviews of implementation strategies in specific areas. In my view, you know, systematic reviews of implementation strategies and other primary evidence on implementation strategies is a great place to start, particularly if you have a specific intervention in mind. We've talked a lot about audit and feedback in these sessions, and I saw later on this afternoon we have a consult on audit and feedback. That's a great example of a case where I would say, like, focus in on what we've already learned and what the key questions are, in that area in terms of optimizing audit and feedback. But that said, I think that a critique of the field and a critique of sort of secondary evidence on implementation strategies is that oftentimes it's not clear, how and why they were even used. Again, so the reporting issue comes up in primary studies, and then that's kind of further obfuscated in systematic reviews of implementation strategies. So Brian Mittman often talks about sort of, it's really less of a relevant question to say, does a strategy work, yes or no? And really important to be asking those questions about why. And I think only then will we be able to kind of understand across settings, if I have this type of problem, this is the type of strategy I might be able to use, and this is how it could work to address that problem. So I think it's sort of less simple than these dichotomous yes, no, does this work, or these 15 strategies work across all of healthcare, because the reality is, or not just healthcare, right? The reality is that the settings that we're working in are quite different. The interventions that we're trying to implement are complex and vary tremendously. So there's so many moving parts that I think it's hard to suss out in that way.
Mm-hmm. Yeah, I might just to kind of follow up on your comment about audit and feedback, not to get too specific about a particular strategy, but I think that the Cochrane reviews indicate that audit and feedback has around a 5% average kind of effectiveness in terms of outcomes. So in my view, I mean, that's important. And I sort of view audit and feedback as being a necessary but not sufficient component of an effective implementation strategy. This is also my systems engineering kind of bias, where going back to the model for improvement, you ask, what are you trying to accomplish? And how will you know if a change is an improvement? You have to have performance monitoring and feedback to answer that question about knowing if something is getting better or worse, basically. So I kind of think it should be baked into just about any implementation strategy, in my view. But if you're happy with the 5% improvement with whatever you're studying, usually we at least hope to do better. So I think strategies need to be augmented with more potentially more intensive and personalized kind of implementation support. So I think facilitation is another one, and maybe you can comment on this, that it seems like most implementation strategies really do need to have some form of facilitation to have the greatest likelihood of being successful. That's kind of my read. I don't know if I'm reading the evidence correctly, but that's how I've designed studies that I'm working on. Facilitation or coaching, that's another word. I kind of use those interchangeably, but.
Yeah, two quick comments, and then maybe 3 quick comments, and then I'll shut up. But one, so Andrea put in the chat, the range of effectiveness on audit and feedback is 4 to 16%. And that's been sort of one of the things in the field is, again, like, if you're using audit and feedback to address a problem that audit and feedback might, be well suited to address, we might see bigger effects. But the other thing that sort of, when we look at these sort of modest effect sizes of implementation strategies, Jeremy Grimshaw made a great point at CERC last year, that sometimes we get down about that, but when you look across a system, or that actually, those small effects actually can make a huge difference if we're scaling up those types of strategies. So I think sometimes we need to not get so sort of pessimistic about that. And then to your point about facilitation, it's interesting as we look at different facilitation models. I think there's a lot of room to sort of, I guess the short answer, yes, I think almost everything that we do involves some kind of coaching or facilitation. And it seems like it's a really critical important part. I also think we need to do a lot to sort of specify the black box of facilitation and what is actually happening. And I know like Julia Moore has been on the call the last couple of days. She's doing a lot. How do we actually train facilitators? Obviously, Joanne Kirchner and others at University of Arkansas for Medical Sciences and the Little Rock VA are doing work on that front. But I think that it's sort of the core elements of what facilitation means and how we actually identify skills of facilitators is an important thing moving forward.
One of the things that I'd like to identify is some of what we've heard throughout the last 3 days in helping to prioritize strategies. We heard some techniques like the tool that CFR has, where you're able to give the scoring on the relative strength or worst severity of a facilitator or barrier. We heard about the nominal group process being used with the NIATEX model. Also, NIATEX has in it the idea of getting ideas from outside the field, as well as, really going back to your stakeholders. Again, nominal group process can be very important. And then we heard about the SEEPS model, which is another way of identifying how to prioritize holistically, where you might want to start with strategies. So I just want to, and then I think implementation mapping is, it has a lot of similarities in approach with the others. So I'm not sure there's necessarily one right answer on how to prioritize, but there's certainly more research to be done, but I think it's a combination of many different methods.
Yeah, I just had a thought too. I think that's an interesting thing to think about is say an audit and feedback intervention has a 5% effect. If you think about, well, 5% over what time period, and does that kind of effect compound over time? If it's 5% per year, that could become very effective over the long term. And I think a lot of those, real effective performance monitoring systems should be kind of put in place, in a sustainable fashion so that they're there. And, if it's something that you track over the long term, I think those systems could be really critical and effective implementation strategies.
Yes, definitely. Thank you for addressing that question. And again, so much time could be spent on each of these, but we're going to try to get through as many as we can and unfortunately not be able to do all of them still. So I think it's about time we move on to the next topic.
Okay, the next topic is similarly prioritizing context factors. So I think that's, Laura, that's your bailiwick, if you want to lead us off on that one.
Yeah, I can certainly do that. And I think that, the two topics of choosing strategies, where do you start and choose, and where do you start with context are actually, highly synergistic problems or questions or challenges or approaches. Because, what we've been saying is that the ideal, that we're choosing our strategies so that they fit context, so that they address context, so that they navigate context, successfully and most effectively. One of the tools that I just want to throw in there too for, prioritizing strategies is a quality improvement approach around assessing effort and impact. So how much effort goes into a particular strategy and how much impact, if you're successful, would it have on your implementation efforts? And that's a way of, prioritizing potential solutions or approaches. And certainly, taking an incremental approach rather than trying to do everything all at once is also a recommendation. So I'm going to go ahead and share my screen, and I'm going to use the question of where do we start with choosing implementation, or where do we start with context? Where do we start with which constructs should we pay attention to? I just want to verify, can you see my screen with the CFR website, the CFR guide? Okay, great. Yep. So if you go to cfrguide.org, and if you do that even now, you can click along with me. And I really want to, highlight this site because there are a lot of very concrete things. So, if you're just beginning, what is the CFR? Actually, the content, all of the content of the published 2009 paper is on this website, including all of the additional files. But what we've done is that we've arranged it differently to help you step through applying the framework to your work. There is a tab for, so the homepage just kind of gives an orientation to the framework. And then we have a tab with the whole taxonomy all laid out. So one of the things we do, we actually go beyond the published paper. And I'm going to pick leadership engagement, which is one of the more active constructs, where we have all of the sibling constructs. So the constructs that are related to inner setting and readiness for implementation inside of the domain of inner setting. We have the detailed description that comes from the published paper. And then we also talk about, kind of close cousins of each of the constructs. And then we give coding guidelines. So for this particular construct, we have a lot of information about, here's some examples, here's what to include under this construct, and here's what to exclude and where to code it instead. And then we have a section on quantitative measures, which is sparsely populated, but we do have, and actually we need to update these sections. And if you know of quantitative measures related to each of the constructs, that is great. You can just email me, or actually there's a contact us page on the website, and I and my team will respond to you, usually, within a very short period of time. So then for those who are brand new to this, we lay out using Cheryl Stetler's kind of seminal paper on different approaches or different types of formative evaluation. And we have some examples of studies that are, within each of these types of formative or process evaluations. And then we go down into, and this is where a lot of the question is, to how do I select the constructs for, to focus in on. And, first of all, within, well, we have a link out to our early published paper that really gives a lot of detail about, and I'm just going to bring this up real quick, about the whole process for quantifying qualitative data. And this is the paper. It's Julie Lowry is my co-author on this paper. It is a methods paper for quantifying qualitative data. And these, this approach, again, can be used with other constructs as well. So now I'm going to go back to the website, and specifically, we have a section on the 3 general approaches for choosing or prioritizing your constructs. And we have used all 3 of these in different ways within our work over time. We have group deliberations where we engage our partners or engage those individuals who are integrally involved or potentially involved with the implementation. And we talk through the list of constructs. And I'll just show you real quick here. This is an additional file 3 in the published paper, but we literally share this. This is just a very simple approach. And we talk people through the meaning of each of these constructs. We have the definition here. And then we use a 3-point rating scale. Is this, most important? It might be important or not at all important. And then we really focus on usually just the really most important constructs. And like I said yesterday, all of this work, it's really important to start with open-ended questions to elicit the story, the complete story of implementation or of past efforts, so that you can kind of do a check. Well, first of all, you want to be able to understand the dynamics of how things are working within, the story or the experience of implementation. But then, and this is another tension that I'm probably going to complicate this process a little bit here. But, the CFR or frameworks like the CFR, they chop up context into bricks or into Legos or into, constructs. And we can look at those constructs like variables across multiple cases to see if they matter across a set of cases. But we also want to kind of test what we're coming up with by taking that independent variable or construct approach. But we also want to be able to understand the backstory of how these constructs may relate to each other. And actually, we've been kind of experimenting and doing some development on what we're calling connection coding, where leadership support may lead to high relative priority. For example, those are two constructs that may be closely related in a lot of contexts. So really trying to push forward into, rather than just thinking of these as isolated constructs or influences, how do they act together? There may be kind of a confluence of a core set of these constructs. All right, so that was back to construct selection techniques. So anyway, we engage in this dialogue to come to consensus on what the most important influences in implementation are likely to be. We also have a stakeholder survey. So we've had projects, and there's a link to a survey that is based on that list of constructs with their definitions. And we just formatted it as a survey. I think it's a 5-point Likert scale or importance scale on this particular survey. And then we just literally aggregate or collate results and do a ranking and choose that way. And then the third way is to have a theory about how constructs may relate together. And in an example of another study that where we used a specific theoretical model, I have to remember what this looks like, is that we took Klein, Kahn, and Sora's implementation model that has, you can see here, each box is a different variable that they measured quantitatively. In our study, we actually measured each of these quantitatively, and we took a further step to map them to the CFR. So then we used a combination of quantitative and qualitative data focusing specifically on these constructs. So using theory in this way is another way to narrow in or target in, focus in on constructs. So I guess I'll stop there. There's a lot more on this site. We have memo templates. We have an in vivo project template that has preloaded CFR codes. And it's a great, I just encourage you to explore it and kind of step through it sequentially.
Yes, definitely. There's so much on that site. It's such an incredible resource, and we're really appreciative of all the work you and your team do to keep it up to date. And so if any other questions about that come up, while we move on to the next topic area, I'm going to throw in a question from the chat or from the Menti Q&A that I've been seeing for a while now that kind of gets at parts of different things. So the question is, should demographic characteristics of staff be included in characteristics of individuals, maybe under other personal attributes, or are these separate from the measures within the CFR?
Whether they're separate from the CFR, I think is a matter of perspective. Yes, these would go under the individual characteristics, but I will just say that we purposefully did not develop that domain very deeply because of the existence of the theoretical domains framework. But I'm not sure that one really captures demographics either. I will say that in our version 2 CFR that we're in the middle of developing now based on user recommendations and experiences, We are adding an attribute code for interventions or innovations. So for example, does it include information technology? Is it a behavioral intervention? Just objective characteristics like that. And I think it's a great suggestion to include a similar construct under individual characteristics that would include those kind of objective characteristics of individuals. And I think, this could be important to capture when in going back to our first conversation about equity issues and racism. It can help us make sure that we're including the voices of minority populations.
Okay, well, it seems like the wrong thing was up for a second, but that's fine because we can address that question. Did anyone happen to have, they're interested in the concept of multiple inner settings. Are there any published papers in which multiple inner settings are described?
That is a great question. I get that a lot from, or actually, I actually have given kind of guidance to people that you can have multiple inner settings, but I'm not conscious of a specific article that has been published around that. But I would encourage you that if that's what's working for you. So by multiple inner settings, I'm assuming that, maybe there are kind of multiple concentric rings, like you have a intensive care unit within a hospital, within a system, or within a state. And so depending on, where your stance is in the research, and be really clear about that, or else you'll drive yourself nuts about what's inner versus outer setting. But if your stance is that, I want to understand how ICUs, interact with the implementation efforts, how hospitals do, and then maybe systems within states, however far you're going. Byron, you have one. Great.
Yeah, so just
as an example of,
I'm not sure where this stands in terms of the study. This is, I think, the protocol, but Erin Line has some work to look at school mental health providers. So the idea here is that, like, many of them are coming from agencies outside of schools and then also working in the school environment. So to what extent does, for instance, the organizational culture of the school differ from the organizational culture of the home agency, and does the alignment of those different settings matter? Would be one way of looking at that.
Great.
That's a great example.
Thanks for sharing that. And I think we have just enough time to briefly touch on the kind of last topic of interest, unless I don't have the slides up, unless we're moving on to the next ones.
Oh, there's organizational structures and COVID-19, I think.
Yes, and I've seen some things about COVID-19 coming in on Menti as well. So we really, so many things, we're not gonna be able to get to them all. So really prioritize on what you think is most interesting. I'm sure we're all willing and excited to hear about any of those.
Yeah.
Andrew has a comprehensive plan for how we're going to roll out the COVID-19 vaccine. So I just hand it off to him.
Yeah.
I think people are just interested in hearing really how you or have heard of or have you seen how people have managed to overcome the new barriers that emerge in that situation.
It's such a giant topic. I've found it remarkable from my own personal perspective. My work has been on implementing CDC guidelines for opioid prescribing in primary care settings, which was pretty, obviously important, but CDC guidelines for COVID-19 are, dwarf pretty much all other public health guidelines that are out there because it affects everyone. And I don't know, I'm speaking personally. I know that we've had all this trouble with masks, and, the vaccine, can't come soon enough. But I think the next challenge we're going to have is that people aren't going to want to get vaccinated. And that's just one of the many different aspects of the challenge that I think is coming and that we have to face. And I think the implementation research community, we should all have an all hands on deck kind of effort. I'm doing a project with Ryan Westergaard, who's the medical director for infectious disease control in the state of Wisconsin. And obviously he is a pretty busy guy right now. He's leading the COVID-19 response. And I just, you know, have to keep all of our colleagues in mind, and all of the hard work that they're doing to try to face this monumental public health challenge. And it's affecting all of us, you know, clearly in ways that are too numerous to count. We'd all like to be together in Madison right now, but here we are on Zoom. So I only have questions and not a lot of answers, I guess. I don't know if Laura and Byron have anything to add.
Well, I will say that as an embedded researcher, and most of my funding comes from actually clinical or operations dollars, and the VA actually has been very agile in giving us the latitude to pivot from the work that was originally funded to address COVID-related issues that our partners are engaged with, that suddenly, you know, become a high priority. And wow, what we had as our original aims all of a sudden just aren't really that important. I don't know if others have been able to, or if that's even an option to, I mean, I can't imagine like on an NIH R01 that you can change your aims or take a break, or, you know, without just enormous impact on momentum and budget. So that kind of comes to mind when you say, wow, all hands on deck. Yes, it would be wonderful if we could put all our brains to the problem. We could get a long ways, but we're also beholden to the structures within which we're working.
Yeah. Yeah, I mean, for my part in running two projects, we had to halt both of them. And, you know, one is we switched all our facilitation from in-person to virtual. We're also doing a mobile health study for alcohol use, and, you know, seeing that a lot of the discussion and, you know, what patients or research subjects are all talking about, you know, isolation and COVID-19 and heavier alcohol use a lot of times kind of resulting from that. So it's affecting everything. And we've had to halt both projects, put in significant IRB changes to try to adjust. I think at minimum, we all have to be really cognizant of the effects of COVID-19 in ways that might not even be apparent immediately. I think one way to address it, if you're doing research, is to ensure that qualitative data collection, you know, most good implementation research includes qualitative data collection. And I think you've got to, you know, rewrite interview guides and things like that to make sure that we're gathering, like, well, how is COVID-19 affecting everything? So we've done some of that in both of our projects. I guess we didn't really need to touch on organizational structures. I'm just going to put a plug in very quickly because that came up in our afternoon breakout session. And I think I'm reading a lot about bounded rationality by Herbert Simon, decision-making under constraints, which I think is so relevant to implementation research. I give a lot of credit to Lindsay Zimmerman, who's doing simulation modeling work in the Veterans Health Administration around PTSD. A lot of her work is bounded on this concept of bounded rationality. And I think there's a lot there in another emerging areas to start learning about. It's funny that these ideas are not new. You know, that book was written in 1976, I think. But finding the right ideas to apply isn't always obvious, but I'm definitely doing it in my work, and maybe that's something that will be a more prominent theme in years to come, because I think the field does need to be moving in that direction.
One of the things I would say about work in the organizational area, we, I think, have so much to benefit from advancing the field by working with communications experts, as well as organizational psychology, business, sociology. I think there's really, we're understanding more and more that we're at a confluence of many, many disciplines.
Yeah.
And the work we do related to implementation and engineering, but adoption is so related to business and marketing and communication. So the more I think we reach out and expand our partnerships, the more we'll bring richness and move the field forward.
Definitely. And those are incredible closing words to bring together the end of this session. It is 1:45, you all at Central Time, and you all have been joining us from all over the world for the past 3 days, and we're so grateful you are all in attendance for this long. We've had incredible conversations over Menti and with our guest faculty and with all our panelists, and it's just been so wonderful. So for everyone who has a video, turn it on because we want to see your faces one final time for all of our panelists and guest faculty. I'm going to close out our day by just saying thank you again. We hope to see you all next year in what will probably be some sort of hybrid virtual short course. We have a post-course survey, which you should get very shortly if you haven't gotten it already. If for some reason you do not get it, send us an email and we will make sure to get it. I know a couple people had our emails go to their junk folders. Also, all the recordings, all the resources, everything we will compile together and get them to you as soon as possible. But some of the recordings take a little longer. We have to edit them and get them kind of compiled together to put them on our website. But we will be communicating with all of you to make sure that you get everything, all of those resources and all of those videos. Also, for those of you who stuck around all the days, we are gonna do our raffle pretty shortly, and we will announce those directly to you and on our Twitter to let you know that you have won. And we are so grateful again to Dr. Powell and Laura Damschroder for volunteering to give these consults. And just again, just a round of applause for everyone, all the speakers and volunteers. We could not have done it without you. This has been an incredible 3 days. So thank you again. And that is our virtual short course. Thanks.
Thanks, everyone.